Thank you, Dr. Meenawat. And let me now have the pleasure of introducing Dr. Surendra Deora, who is a cardiologist and associate professor at AIMS Jodhpur. And Dr. Deora has had vast experience of working in Delhi, in Jaipur, has more than 50 national and international publications. He's a speaker and investigator of many clinical trials and has delivered lectures in various cardiology conferences. Now, Dr. Deora is going to speak to us on a very interesting subject, clinical inertia, which all of us face in practice every day, whether it's initiation of insulin, whether it is intensifying therapy for type 2 diabetes or for hypertension or for anything else. I think clinical inertia is something that we really need to beat to really give the maximum benefit to our patients. Dr. Deora, the stage is all yours.
Thank you, sir, for nice introduction. So, am I audible?
Yes, please.
Okay. So, first of all, I would like to thank you, Dr. Anand Meenawat, sir, and the whole team of Knowledge Forum for inviting me to talk about this one of the aspects which is very important in the clinical management of heart failure patients, the clinical inertia. So we all know that the inertia is not only from clinical side, but also on patient side and sometimes on the system side. So I will be talking about our side, where is the inertia. So I think many aspects of heart failure has already been discussed about the. Can I shift my slide? Can you shift? I'm not able to shift it.
Power. You have to put it in the slideshow mode, please.
I'm not able to shift my slide.
Dr. Deora, please put them on the slideshow mode.
Okay, sir. Let me wait to it.
Just at the bottom, slideshow mode.
So it is in the slideshow only. This is on slideshow mode only.
The technical team will probably help you then.
So your slides are visible. Just click on
the slide, Dr. Deora.
Yes, sir. No, this is the first slide.
Yeah, this is a heart rate.
Second slide, not. I'm not able to shift my slides.
Clinical inertia impacting.
I think this is not on the slideshow mode because the slide is showing smaller in size. If you can go down and put it on the slideshow mode, that's what I think. I think probably that's the reason.
Let me see why it is like this.
Yes,
okay.
Yes, that's it. Yes. Just go down and.
Okay, we'll do that. Yes, now it is there. Fine, perfect. So I was talking about the inertia which is on the part of clinician, which is impacting the heart failure outcomes, and it is very important to get out of this inertia because every readmission it increases the mortality of these patients, and India is going to be a capital of heart failure, looking to this incidence and prevalence of coronary artery disease. So when we look at the mortality of these patients, it increases with every month, every year. The mortality increases. The mortality in hospital mortality is around 10%, which increases up to 30% at 1 year. At 3 years, it may reaches up to 50%, and 60% unadjusted 5-year mortality rate is also been there. Again, I got stuck. I don't know what is happening. So there's some problem from their side. Can technical team please help me? Because again, I'm not able to shift my slides.
Yeah, I will ask him to just take care.
So again, I will go to the slideshow mode. Yes, yes, now it is again. Okay. So yes. So 1 out of the 4 Indian heart failure patients with reduced ejection fractions, they fail to receive the optimal guideline-directed medical therapy. And when we look at the drugs which we are giving in these heart failure patients, diuretics is almost being given to all of these patients, but all other drugs are given in the tune of around 30 to 50%. So there is a big lag in giving optimum medical management to these patients. Again. Again, I'm not able to shift it.
You just have to click the down arrow in your keyboard so that the next slide will come.
I'm doing that. I'm doing that. Initially, it moves. Then after a few seconds, it doesn't. I'm doing both down and late, both.
So just click on the mouse on the screen with your mouse.
What should
on the
I
screen,
click?
sir, not on the anywhere on the screen, sir.
I'm
Not
clicking
on
on
the
this.
go to webinar.
Okay.
Yeah, it is moving.
Okay. So I will click
Thank
on
you,
the
sir.
screen only.
Yeah, you have to
So
click on the screen only.
fine. So more than 30% of these patients with heart failure with reduced ejection fractions, they are not being treated in spite of there is no contraindication for the drug. Now, this is the data from the US CHAMP Heart Failure Registry, where they have included patients who were taking at least one drug of the heart failure. And what we could see that more than 30% of these patients who were without any contraindications, they were not being offered any management. So in spite of all the guidelines which is there to assist physicians and the practitioners to give evidence-based therapies, there are many gaps in the clinical cares. So what do you think that what is the reason for such resistance in achieving optimum medical treatment or giving these patients guideline directed medical therapy to the optimum medical dose? So clinical inertia not only means that to start a medical management or to give some particular drug, but also it has to be given up to the optimum dose which was there in clinical trials. So this clinical inertia has to be managed, and evidence-based physicians should be aware of the dose which has to be given to these patients. So what are the important factors which is there in the mind of the treating physicians that these patients they have? So one thing, it is always there when the patient comes in a stable hemodynamic state, the physician thinks, the treating physician thinks that no, patient is stable, I will not increase the drug dose. If I will increase the drug dose, it may increase the cost of the therapy, but simultaneously it may increase the risk factors. Second thing, the importance of giving the optimum medical management may not be there with the it may not be there in the mind of the patients and in the mind of the physicians, and it is thought to be of a low risk. Third, patient and provider inertia to optimize therapy. Again, as I said earlier, the therapy has to be optimized to the guideline dose at least. So another important point about the side effects and other problems which these patients have, other renal problems and other major organs involvement. So, but what we see in reality is that the mortality is very high in this patient. As I said in my first slide, in hospital mortality is 7%. It may increase to 30 to 40% in 3 years. So annual mortality is 6 to 20%. With each rehospitalization, it increases the cost of therapy to the hospital. It increases the cost of therapy to the patient, to the state also, and the The sudden cardiac death, we should know that it is more common in patients who are relatively stable in NYHA class 2. So these patients in NYHA class 2, they have high chances of having sudden cardiac death. So even if the patient looks stable, optimum medical management should be offered to these patients. So inertia on the side of clinician is because of lack of awareness. What is the latest guidelines? Sometimes the clinicians are too busy with the number of patients they are looking after. Third, they have little bit limited experience in the management of complex heart failure patients. And third, fourth thing, which is always there in mind, my patient is doing fine, so why should I change the therapy, or why should I shift from one therapy to another therapy? On the patient side, yes, there are many things reluctant to change. They don't want to change. Poor adherence of the patients to the given medications, many comorbidities, and they are not aware of the disease what they are having. And of course, in India, if you look at the practice, everybody is paying from their pocket. So insurance and government scheme doesn't cover for the outdoor medical management. So that system is also responsible for the same. What things physicians say? So again, as I said, patient for him, if the patient is stable, nobody changes the management. Why should he change the management? If the patient has a mild heart symptoms of heart failure, it is not going to affect him, and to inconvenience. If you change the treatment, it will be inconvenient to the patient and to the physicians also. And it is always, thought, it is in the mind that if the patient, if I will change the medication, if it increase the cost of therapy, it may have side effect, it will involve more, it will be myself, and it will increase my work also. So these are the some important points which is there in the mind of the physicians. Another important point, many times we see on the prescription, it is written as a stable heart failure. Actually, heart failure is not stable. It is stable in maybe from a symptomatic point of view, but it is always a progressive disease. The only thing what we can achieve with the GDMT, with the guideline-directed medical therapy, is to decrease the progression of heart failure. So it is basically a stable, persistent heart failure, what we can say. So, stable, it may be symptomatically stable, but the disease per se is continuously ongoing. It is a persistent heart failure, which is stable at that moment. So, if we don't start the GDMT, are we too late, or should we do something more? Yes, because if we will not do anything, the patient will suffer with time. Although he looks stable at that point of time, patient may suffer or may have adverse the side adverse effect of the disease per se, may have a sudden cardiac death also, looking a stable NYHA class 2 patient. Patients deserve better. The best of the therapies which are available, if the patient can afford, should be offered. The earlier we act, it is better for our heart failure patients. As I said earlier, each rehospitalization, it increases the cost of therapy to the patient, to the hospital, to the state. So we should give them as early as possible the guideline directed medical therapy with the best possible medications which are available with us. So all physicians who are treating these patients, they should acknowledge the relevance of and the problem of the clinical inertia, and they should be updated with the latest guidelines and should convince the patient also simultaneously. So how to implement an ideal heart failure reduced ejection fraction therapy in these patients? So these are the potential qualities of an ideal therapy for the purpose of implementation in the real world practice. So lower the number of drugs, the compliance is better, we all know. Second, these things we should know that the drug which we are prescribing, it improves the survival and it prevents the rehospitalization. It improves the morbidity of the patient, quality of life, and functional status of the patients. The benefit starts appearing within a few days or week of initiation. The drug should be exceptionally well tolerated and safe, should not cause hypotension, and should not have much adverse effect on the other important major organs. In heart failure patients, it is the renal involvement which is very commonly associated with them. And of course, looking in the Indian circumstances, it should be affordable and accessible at all hospitals or all the nearby medical shops. So, if you look at the practice in Western Rajasthan, people are coming from far distance away, and if we are writing something which is not available at that place, then chances of non-compliance is very high. So, therefore, it is important to have these aspects of treatment which we should take care. What is the latest recommendation of GDMT? So, guideline-directed medical therapy, it is the foundation of the heart failure care. If you look at the interventional therapies of heart failure care, they have not much affected the quality of life of the patient. Looking in the Indian practice also, so still the medical therapy is the cornerstone of heart failure therapy. And what is more important is the compliance of medication, which is the most important thing which should be prioritized in our clinical practice looking to the Indian scenario. So the recent ACC 2021 document says that the guideline directed therapy should be started as early as possible and with the minimal dose of the drug, all the drugs, rather than starting one drug at a higher dose, another at a minimal dose. So start all the drugs simultaneously, which improves the survival of the patients at a minimal possible dose, and then it can be titrated slowly. Then after 2 to 4 weeks or 1 month, it can be adjusted, the drug can be adjusted, increase the drug gradually to the maximum tolerated drug, and simultaneously getting the kidney function test and other major organ laboratory investigation if needed. So the best way to do is that always assess the side effects, look for the volume status of the patient. You can adjust the diuretics. If the patient is not dyspneic, you can decrease the dose of diuretics and you can increase the dose of disease modifying drugs. So most of the prescriptions, what we see is that they all heart failure patient, even if they are not fluid overload status, they are being given diuretics. So rather, in fact, these patients, the dose of diuretics should be decreased, and the other drugs like ACE inhibitors, ARBs, beta blockers should be gradually increased. And this should be repeated after 1 or 2 months, so to the best possible dose which the patient can tolerate in their clinical experience. So these are the drugs which are there in our basket, and we all are aware of these drugs. ACE inhibitors and ARBs, beta blockers, we are using for long, but almost 30 to 50% of the patients only receive these drugs. Mineralocorticoid receptor antagonists are also disease modifying drugs and have been shown to decrease the mortality. ARNIs, I will not say it is the latest in the armamentarium, but yes, it is one of the drugs which have been shown to have an added benefit even in those patients who are taking the ACE inhibitors or ARBs. Other symptomatic, the drugs like you can do like isosorbide dinitrate hydralazine combinations in those patients with renal failure, black patients, ivabradines, and diuretics. So this is the conundrum of the drugs which is there in our basket. So we all know about this, but what is more important is to give them at an appropriate dose. So I think which therapy we should give in these patients to improve the clinical outcomes. This has been discussed a lot at many forums. ACE inhibitors or ARNIs. I will not discuss it in detail because it has been discussed earlier also. So the only thing which is new is that initially, previously it was that ACE inhibitors has to be started, and those patients who are stable on ACE inhibitors, they should be shifted to ARNIs. Now the concept is direct to ARNI approach is now recommended. You can give ARNIs to your patients at low dose, although you can start at 50 BD and then gradually up these drugs. So de novo, if you start, it has a superior benefit. There is a rapid improvement in symptoms, physical functioning, quality of life, and of course, because cardiac reverse remodeling effect is always there with ARNIs. If you look at the mortality benefit, it has been discussed again many times, paradigm HF 5-6-year-old trial. So there are all part of MIS, cardiovascular death, hospitalization, all cause mortality, primary composite outcome, everything is, it decreases 16 to 20%. In Indian patient, when we look the data with this ARNIs, sacubitril valsartan, the
Dr. Deora, we are not able to hear you. Dr. Deora, you are muted.
the benefit or around 7-8% of mortality benefit when we give it to the RNA. So it should always be tried, convinced to the patient that if possible, he should take RNAs along with the other guideline directed therapies. So in conclusion, we have enough drugs in our armamentarium. Medical therapy still is the cornerstone in managing the patients of heart failure. And from a physician point of view, so that inertia should be, should be taken care of. The clinical inertia should not be there. That is the biggest challenge. If continuously the physician will, convince the patient, then the patient will also get convinced. And if a systematic follow-up of these patients will definitely decrease the morbidity and mortality in these patients. So I thank you, all of you, for patient listening. Thank you very much, sir.
Thank you, Dr. Deora, for speaking about clinical inertia, which is so important to take care of when we are trying to intensify or initiate appropriate therapies.